Thank you very much. Good afternoon to all. First of all, I convey my sincere thanks to the scientific committee for giving me this opportunity to talk on heart diseases in pregnancy. As we all know that pregnancy places a normal heart under immense physical strain. If the heart is already compromised by an existing abnormality, this can result in a poor outcome for both fetus and mother. The onset of pregnancy marks the beginning of progressive and profound changes in the physiology of the cardiovascular system. Pregnancy in a patient with existing heart disease should be carefully planned. There are some anatomical variations which we should be aware of it. There are the physiological changes in pregnancy. The blood volume increases by 30 to 40%. We all know that. It starts increasing from 12th week, peaks at 32 weeks, so that the cardiac elements puts the heart under strain at this time. Plasma volume increases by 40%, RBC volume by 20%. Cardiac output increases by 30 to 40%. Heart rate increases by 10 to 15 beats per minute. During labor, each contraction, displacement occurs. Displacement of 300 to 500 ml of blood into the general circulation. In the first stage of cardiac, output increases by 30%, second stage 45%, and third stage 60%. And 1 hour postpartum 30 to 50%. These are the stages when the heart can go for the failure. Pregnancy changes mimics cardiac disease. There are many pregnancy changes which mimics the cardiac disease. As a clinician, we should be all aware to differentiate these two things, like breathlessness, weakness, edema, syncope, tachycardia, splitting of the first heart sound, murmur, systolic breast beat, displacement of apex beat upwards to the left side, hemodynamical changes during labor and delivery. We all know that it displaces a large amount of blood. Now we go to the postpartum hemodynamic changes. Blood loss occurs during delivery. Temporary increase in the effective venous return due to relief of caval compression and auto transfusion. The hemodynamic changes persist for few weeks postpartum, and it may take up to 12 to 24 weeks for the parameters to return normal in some patients. Clinically, we know there are some warning signs: worsening dyspnea or dyspnea at rest, increasing rales and rhonchi in the chest, worsening chest pain with exertion, loud cardiac murmur, cyanosis or clubbing, increasing edema, increasing in limitation of the daily activities is very important history. Here is the New York Heart Association classification of heart diseases during pregnancy. This is the gold standard till time. Class 1 asymptomatic, class 2 symptomatic with heavy exercise, class 3 symptomatic with light exercise, class 4 symptomatic at rest. Clinically, we should deal these patients meticulously and carefully. Causes of maternal deaths: puerperal cardiomyopathy is very important. Myocardial infarction, aortic dissection, cardiomyopathy and myocarditis, primary pulmonary hypertension, secondary pulmonary hypertension, endocarditis, grade 4 heart failure, dysarrhythmias. Indications for admission is very important. This is needed for our medico-legal purposes. So we should carefully classify the patient in NYHA 1 or 2, and we should maintain our papers accordingly. Elective admissions are advised NYHA 1 to 2 weeks before EDD, NYHA 2 28 to 30 weeks, NYHA 3 and 4 irrespective of period of gestation as soon as patient comes. To change from oral anticoagulation to heparin, early pregnancy, 36 week in patients on anticoagulant. Emergency admissions are advised when the patient is showing the signs of deterioration of functional grade, symptoms and signs of complications like fever, persistent cough, basal cramps, tachyarrhythmias. When the pulse rate is more than 100, JVP is raised by 2 centimeter, anemia, infection. Guidelines for management: avoid excessive weight gain and edema. This is the gold standard guideline. Avoid strenuous activity, avoid anemia, early detection of problem. Factors causing the cardiac failure are anemia, increased physical activity, fluid or dietary access, infection, acute rheumatoid carditis, SABE, HDB, arrhythmias, twins, hydramnias, overdistension. During management, first and foremost thing which we should offer to the patient is bed rest. We all remember in our post-graduation days or in our UG days, we were used to see the patients lying in the special room besides the labor ward for months together. So that were the bed rest for the cardiac patient. It is very important thing. It increases the venous return to the heart, improves the renal perfusion, induces diuresis, decreases the load on the heart. Antepartum in management, dietary salt restriction, no extra weight gain, diuretics. Most commonly used is a chlorothiazide, watch for deterioration, prevention and treatment of anemia. Class 3 and 4 are advised. MTP, hospitalization, antibiotic prophylaxis is of course a must thing. Measures to be taken during labor and delivery in lateral or propped up position. Adequate pain relief should be offered to the patient. Restriction of IV fluids, not more than 75 ml per hour. O2 inhalation by mask, pulse oximeter, close monitoring. No ergometrines is a gold standard thing. Antibiotic prophylaxis, thrombosis prophylaxis, prevention of postpartum pulmonary edema. Preferable to have an ICU facility with cardiologist. Cut short the second stage. These are the this I prepared for Fortis Hospital, Udaipur last year. So there are many slides. I'll just skip all those slides. Indications for LSCS in this patient are mainly obstetrical. Obstetrical indications, coarctation of aorta, Marfan syndrome with dilated roots of aorta. We should prefer the epidural anesthesia, narcotic conduction analgesia or GA in cases of pulmonary hypertension. Advice in the time of discharge, continuing the medical treatment, we should refer the patient to the cardiologist again, avoid infection, reassessment after 6 weeks or earlier if some complications occur, iron supplementation, cardiological consultation for definitive management of the heart disease. These are the specific congenital disorders. We should offer endocarditis prophylaxis, which is injection ampicillin 2 gram stat and injection gentamicin 1.5 milligram per kg IM or IV followed by one more bolus dose of ampicillin 8 hours later. High risk patients are those with prosthetic valves, past history of SABE complex, CCHD. Medication guidelines during pregnancy are anticoagulation. 3 common agents used during pregnancy are unfractioned heparin, low molecular weight heparin, and warfarin. This is given by the 6th American College of Chest Physician Conference. Warfarin crosses the placental barrier and can harm the fetus. Fetus safe during breastfeeding. Warfarin embryopathy, we should be all aware and we should be careful about it. Unfractioned heparin is one of the things which is very safe in our hand. This is disease load. Heart disorders are 1% of all pregnancies, 10% of the maternal obstetric deaths. This incidence is though declining. Management, we have discussed it. I'll skip some slides very fast. Now to contraception. We have choices. The best choice is barrier contraception. Indication for MTP in this patient are Essen-Menger syndrome, primary pulmonary hypertension, NYHA grade 3 or 4, heart transplant, coarctation of aorta, Marfan syndrome, severe aortic stenosis, termination should be done before 12 weeks of gestation. Contraception we should think of, or we should primarily offer this contraception to the male partner. Conclusion, pregnancy causes significant hemodynamic changes and imposes an additional burden on the cardiac patient, especially around the time of labor and in the immediate puerperal period. To achieve a successful pregnancy outcome, a clear understanding of these hemodynamical adaptation as well as meticulous maternal and fetal surveillance for risk factors and complication throughout the pregnancy is essential. Along with that, we should work in team with ICU setup, with cardiologist. Appropriate contraceptive and family planning should be advised. Referral to a higher center, especially in presence of moderate to severe diseases. The efforts for team should consist of obstetrician, cardiologist, anesthetist, cardiothoracic surgeon in cases of congenital anomalies, neonatologist, pediatric cardiologists are mandatory to ensure optimal results. Thank you very much. We all should have a special dedicated corner reserved in heart and brain for special pregnant patient, and one of them should be for the heart disease patient. Thank you very much.